I want to welcome everybody for joining what I am confident will be an interesting and entertaining conversation today. I'm Erica Galvez. I'm the CEO of Manifest Medics. We are the largest nonprofit health data network serving the state of California. I am joined by several esteemed colleagues today to have a conversation about the implementation of the data exchange framework. Now, we teed up this discussion today because we've had lots of conversation about the data exchange framework itself, and I would think of those conversations largely as policy discussions. But we're well into the implementation phase of the data exchange framework, and we haven't yet hosted a conversation, a pretty candid conversation, about those implementation experiences. And while we're not that far into it, I think it's a good time to start sharing some perspective. So we've shaped the conversation today, or the webinar today, as a dialogue. If you were hoping that we would bombard you with slides, that is not going to happen. Hope you're not disappointed. And I'll go through just a few quick housekeeping items to make sure you have a sense of the environment that you're sitting in with us today. All of your lines are muted. So if you're eating lunch, feel free to chomp away. No one can see you. I filled my tea freshly before this conversation, so I'm going to just sit back and enjoy this discussion myself. You can't chat with each other through your typical Zoom interface today. Sorry about that. We've disabled that. However, you can ask questions, and I will do my very level best to make time at the end of the conversation today to answer some of those questions. That box is at the bottom of your little screen. And then finally, want to make sure everybody knows we are recording this session today, and so we will make that available after today's conversation through all the typical channels. Okay, so with that housekeeping out of the way, I want to introduce, or invite my colleagues rather, to introduce themselves to the group. And I'm going to play musical squares on my screen just because it's easiest for me. So maybe we go in order of David, Adam, and Krishna.
My name is David Ford. I am the Vice President of Health Information Technology here at the California Medical Association. In that role, I've been very involved in the data exchange framework since it was an idea kicking around in the legislature, up through our outreach and education grant last year, reaching out to literally tens of thousands of physicians up and down the state to talk about their views on the data exchange framework. Happy to be here and happy to be part of the conversation.
Thanks for joining us, David.
Hey, I'm Adam Davis. I'm a physician informaticist at Sutter Health and oversee our interoperability efforts there. Have been involved in commenting on the development of the California Data Exchange Framework and worked closely with CHA on advocating for the needs of the providers and patients in the hospital, and the implementation of the California Data Exchange Framework at Sutter Health and the conversations with the broader Epic community of the state.
Adam, thanks for joining us.
Krishna Ramachandran, thanks for having me. Senior Vice President, Health Transformation, Provider Adoption at Blue Shield of California, with a $24 billion health plan serving 5 million members in California. I'm the executive sponsor and owner of the data exchange work at Blue Shield, and we've spent many decades in this work, so excited to share some of that with you all. My background prior to the payer side has been in the provider side as well as in health tech. I used to work at Epic for about 8 years prior to getting to the other parts of the healthcare system. Thanks for joining us, and good to be here.
Thanks for joining us, Krishna. This will be fun. I'm going to start with a really easy question. I think it's easy. And Krishna, since you're the health plan kind of representative here, maybe I'll start with you, but would really like to hear from everyone. And I'm curious, just how are you feeling about the data exchange framework so far? What were your expectations? Is the data exchange framework meeting those so far? Kind of what's your initial assessment of implementation, recognizing we're in the first year?
Yeah, I was reflecting on this. I was thinking of the Gartner Hype cycle came to mind, right? You're sort of in this, all these phases of launching, and so certainly we were in this peak of inflated expectations at one point, maybe last year. as we had the signatures coming through. I feel like we're somewhere in the trough of disillusionment to the slope of enlightenment. Like it's somewhere in that journey yet. And obviously, I'm always a glass half full person, so I feel like we will be up the slope of enlightenment and to the plateau of productivity. But so far, I feel like we're definitely in the trough, right? We've got people signed, but just a fraction are actually signed and put a sort of data exchange method in the directory, and particularly as a payer side, we're not getting any data from an operational perspective. Certainly, I know there's a data exchange happening from a treatment perspective, which is fantastic. So definitely very eager to get up the slope and continue to light up a number of meaningful use cases that they can really help members, patients, just providers, reduce admin burden, as well as just streamline how we deliver care in our state.
Yeah. David or Adam, additional thoughts?
I guess I'd say if I were to grade the implementation of the data exchange framework, I think it's still an incomplete. And possibly just because I'm sitting in Sacramento, this is how I view the world, but there's definitely still some policy work that needs to happen to put the rest of the structure around the data exchange framework. But that being said, we do have 3,000 something entities that have signed. We're seeing some really great energy and some interest from non-traditional parts of data exchange. The community-based organizations have been some of the earliest ones to raise their hands and say they want to be part of this, and that's been really interesting. It's something I think I would not have predicted coming in to the whole process of the data exchange framework, but I really would like to see us sort of close those last gaps, get past that last mile, get the rest of the structure in place, so that we can really move forward together.
Yeah, I'm going to come back to that policy topic, even though we are in implementation. I can't resist a little bit later. Adam, before I do that, thoughts from your perspective on how the implementation is going?
Similar thoughts. Like, I don't think it's been incredibly impactful yet. The way that I like to think about it is what's the delta between what we're doing in California, what the feds require through various information sharing regulations and now the TEFCA on-ramp. And there are some significant differences, and some of those significant differences are potentially exciting, but I don't think they played out yet. As the people who've been really detailed at this regulation know, there's basically 3 requirements for the type of sharing you have to do. One of them is query exchange, which is very similar to what the Fed requirements are. And in fact, many of our systems are doing that through national exchange networks that already exist. Now, there are some subtle differences there in the purpose of use that is required. Many of us, one of the things that the California Data Exchange Framework failed to do, though it enunciated which purposes of use we needed to be able to respond to, it didn't create standards for how to do that. And so that's still an area, I think, of discomfort for a lot of organizations. The second requirement is to respond to orders or referrals electronically. For the referrals part, there are some standards around that. Some people are able to do that. We are able to do that through Direct Secure Messaging, but we are unable to do that for orders. And I don't think any health system is able to do that for orders yet. So that was sort of an interesting requirement to put in because there's really no technical standards around how that could be done at this time. The third requirement, which I think is the most like in the short term exciting, is the ADT subscription model. We've had those sort of requests bouncing towards us for a long time. There's lots of great use cases for that, and we are hopeful that through the QHIOs connecting with each other and everybody giving their ADT information to the QHIOs, we will both, as producers of ADT messages, be able to say, hey, we're not going to be managing this anymore. You guys can go out and contact one of your QHIO, and they'll be able to provide you with that. And also as receivers, that we will now be able to subscribe and get a fuller picture of where our patients from whom we are primarily responsible for their care are getting care. And so that's the thing that really the feds haven't really addressed beyond needing to send a message to the PCP, but that's not really panel management. And so I am excited for that, and I'd like to see how that develops in the next 6 months. But we have not yet benefited from that, but we're hoping that we will.
That's so incredibly helpful. I think my greatest excitement about the data exchange framework is also on the ADT front. I would really, in my lifetime, like to see us have an entirely connected digital health data safety net that at least provides ADT notifications to the care teams that need them. In David Ford's world on the value-based care front, that is kind of a make or break piece of data. I want to get Assembly Bill 1331 out of the way here early in the conversation, because that's a thing. And we were very disappointed at Manifest to learn that that would not move forward out of appropriations. I suspect there are mixed feelings amongst my colleagues about that bill today. It would have given clearer instruction to the state on governance, and it would have provided some enforcement authority to our state colleagues. And so I'm curious, any reflections from any of you on the fact that AB 1331 will not pass, and what we may need to be thinking about on that policy front going forward as we implement?
I mean, from our perspective, there's two parts of that bill. There's a governance and there's the enforcement. And I think, right now, I think having some time for sort of the community to deal with the regulation without enforcement actually provides some ability to come up with community norms and sort of see how it can function, given that there's a lot of, it was a very short regulation. And so there's a lot of vagueness in it. And I think sort of seeing where those lines are before we have punitive measures is helpful to those of us who are trying to be good performers in this regulatory environment. The second piece is the governance. And again, I think that there is a need for governance and there is a need for a law which provides what the governance should be. I do think that the structure of the governance really matters, and having more like health IT expertise in the governance in the next draft of the governance bill would be very helpful, because I think one of the things is, again, that specificity of how exchange occurs, what the norms are for exchange, would really help with compliance. Because compared to like TEFCA, if you look at how many pages of specs there are when you go to TEFCA versus California Data Exchange Framework, and I think that's just a lack of subject matter expertise in governance, which is all well intentioned, but really there's some very technical things that need to be worked out about how we're going to do this.
Great point on the technical front. David Ford, my friend, I know you must have thoughts about this.
Yeah, I do. I think that on the one hand, I wasn't terribly surprised by what happened in Senate appropriations, just because we, in Sacramento, we came out of a state budget process that was very, very ugly. And, where the state had to cut whatever it was, 50 or $60 billion out of the state budget. And I think it's challenging in that political environment to then say, well, now we're going to create this new state board that, if you take the model, which everyone seems to do, of Covered California, it's going to have, as a board, it has to have staff, it has to have analysts, lawyers, right? It's not a cheap thing to create a board like this. And so I think from that perspective, I wasn't overly surprised that the legislature thought, hey, with what we just went through in the budget, this was not the year to do it. But I agree with Adam, it still needs to happen. We do ultimately need to be able to answer the question that so many physicians give to CMA. So you want me to sign this thing, so what happens if I don't? And at some point I need to have an answer to that question, right? Because right now I don't have a good answer. But the other thing is, there's a lot in Sacramento, I think, in the politics of the data exchange framework. There's a lot of just everybody talking past each other. I think that, our CMA, a lot of other organizations were sitting in a position of support if amended on the bill. There were some pretty serious things that we needed amended. Adam's point about needing expertise on the board is well taken. Unfortunately, the legislation, the conflict of interest rules were written so tightly, you wouldn't have been able to get good experts on the board. And that would have been very challenging in something very technical like data exchange. There were things like that I feel like we could have worked out, and there just wasn't sort of a good venue where we could have that conversation, hash some of those issues out. And I think we, at least on the policy, the money thing was still going to be hard, but I think on the policy, I think we could have gotten there this year.
Yeah, that's those are all very, very well taken points. Krishna, any thoughts on AB 1331?
Yeah, I mean, we were in early support of the bill. Definitely thank Dr. Jim Wood for like the leadership in the bill there. So definitely disappointment, because I think it would have created more clarity, more sort of like a neutral party to help us further the conversation. I mean, given David's point as well, like what does it mean to not comply, or what is it? So I think, yeah, it would have been good to have more enforcement, more sort of clarity there. And so disappointed, but hopeful as well that we'll come back and continue to sort of push some of these topics forward. So.
Yeah, okay. Well, I know that was a multi-year effort. So I am going to enter the rest of this conversation with that just in the back of my mind, and invite others to also, I think, future opportunities, if they're legislative, are probably a multi-year process. Let's talk about the positive for a minute. I want to ask for each of your perspective on what you're seeing in by way of implementation thus far that you would consider a success for the data exchange framework. And I will add some thoughts after we hear from each of you. But curious, any surprises, any opportunities that come to mind immediately for you around scaling some of those early wins?
I think that we don't have any early wins yet, because the ADT, we have not got any information from the California Data Exchange Framework. We also the way that we have implemented is we've said, we do care quality. So it hasn't changed our connection so far, except for this ADT piece, which I'm hopeful in the next 6 months. Like, I've already answered internal questions from different sort of programs that are like, hey, we need to know when our patient's seen at XYZ hospital. We're not seeing that right now. I've already answered, hey, we have a new solution that I think over the next 4 to 6 months will be implementable. And so that's the win I'm looking for in the short term. But we'll see how that plays out when we submit our panels to our QHIO.
Okay. It's a wait and see. David or Krishna, any early wins that you think are worth amplifying or highlighting?
Well, I mean, if you take a step back for a moment, first of all, let's not lose sight of the fact that we have a data exchange framework is actually a pretty significant win. I mean, for those of us who have been around this, going back to the HIE cooperative agreement 15 years ago, how long and how much effort and how many different legislative attempts it took to get us to the point where we are, where we do have this framework and we are making progress. It's a win in and of itself. But beyond that, I would point to a few other things. We have a pretty sizable number, I think more than 1,000 small practices that have signed the DSA and that are, getting up and running on data exchange framework statewide. And I think that's interesting just because, remember, those folks don't have to for another 1.5 years. And so the fact that so many of them have come in early shows that demand was there and that they really wanted to be involved in data exchange. By and large, small practices are not the folks who are holding the data. They're the folks who need the data to treat their patients. And they're coming forward and they're raising their hand and they're saying, yeah, I want to be part of this. So I think that's, in my world, I take heart in that why I think ultimately we will get there, because the more physicians find out about this, the more are coming forward and saying they want to participate.
Good point.
Yes.
Krishna?
Yeah, from my side, I think some maybe process wins, right? Like, I think the fact that we've got the data sharing agreement, we've got policies and procedures, we have the qualified health information organization program. I think that's nice to at least have the sort of scaffolding and process. I think to David's point, it's worth taking a step back and celebrating those wins. I certainly like the engagement from like the social services and community-based organizations, like that breadth of organizations leaning in, government agencies, that's been helpful and impressive. It's nice to see people wanting to sort of have a seat at the table and wanting to sort of like be a part of this journey there. So that's been good. And the fact that we're having conversations like these today, this is a moving from policy to implementation to actually action to insights and transforming healthcare is a painful, hard journey. And, we have to start this journey somewhere. And so I'm glad we're sort of in like chapter 2 of the journey, and better than not starting the journey at all. And so it's been good from that perspective. So anyways, those are some sort of wins and thoughts that come to my mind.
That's great. That's great. I'm going to add one to the pot of goodness. Manifest MedX has been on the national networks for a while. Adam, you mentioned a lot of exchange that your organization engages in around existing connectivity through national networks, and the same is true for us. However, we have not historically engaged in a lot of data exchange with other qualified HIOs. There are 9 that have been designated thus far by the state, and MX is just one. We've seen interactions historically with organizations. I'm going to name Health Gorilla, for example. We've shared data, I think, bidirectionally with Health Gorilla and their clients for some time, but other qualified HIOs we have not, and we do now. Those pipes have been built. Some of that data is flowing. Now, the next thing we'll be looking at is the quality of the data, right? As we start to build the pipes and the data starts to flow, then I think there's a quality question, and there's a virtuous cycle that is important for all of us to engage in around that data quality to get to what you described, Krishna, which is the actual use and the insights that derive downstream from that. So that's one I do want to make sure we highlight for everybody that I think is net new, and I think it's driven largely by the data exchange framework and moving into the implementation stage of the program. I want to get a little bit tactical since we're talking implementation today, and David Ford, I'm going to pick on you here because the last time I checked, 80% or more of the organizations that had signed the DSA, right? They've taken this step to say, either I'm obligated or I'm not obligated to sign the DSA, but I'm going to do it. I'm going to sign this agreement. But they have not populated the methods by which they will exchange in the DXF directory, which, Adam, you were describing those exchange approaches. That's ADT, that's responding to orders, that's CCDA exchange. And this feels like a very kind of ground game challenge to me on the implementation front. And I'm going to go to you first, David Ford, because I know you survived the meaningful use years and you work with a lot of providers. And there was a lot of ground game that had to happen in order to make that program successful. I'm curious if you think there are lessons from that meaningful use experience that we could apply here to increase that percentage of organizations that are actually putting entries into the directory. That's how we know how to exchange with them, right? I mean, they're not on our network. That's the only way we know how to exchange with them.
Okay, well, let's not do what we did in meaningful use. Okay.
That's a lesson, right?
Let's start there. And I say that tongue in cheek. We all know what a sort of a grind meaningful use was for so many physicians, but I can make that comment a little more specific. And Erica, you and I both talked to the folks who wrote meaningful use on a pretty consistent basis, and I've said this to them, so I think I can say it publicly too. It was way too complicated, right? And so I do think I think the more sort of simple we can keep this for practices, the more uptake we're going to get. and the meaningful use experience was that even though many of the physicians who started on that journey dropped out because they just saw how complex and how complicated it was. So let's avoid as much complexity as we can. The other thing we had, though, in meaningful use, and full disclosure, I ran California's Regional Extension Center for 5 years, but we had those regional extension centers. We had a lot of intermediaries who could go out and help physicians, sit with them one-on-one, and talk to them about this, how this works. This is how you implement an electronic health record. This is how you use the electronic health record. And I think, that's something we did have, we still do have, because they're still in the field, those data exchange framework grants, which have been pretty successful. Unfortunately, I think in these budget times, we're probably not going to see more of that, although it would be nice if we could have more resources put into supporting those small practices and the safety net practices. And then, I think the third thing that we learned in meaningful use is that even with all of that, a lot of small practices and safety net practices, they still needed help. They still needed someone who could aggregate them. We saw just a million IPAs, hospitals, medical groups that had, EHR adoption programs for the physicians in their network. And I think I'd really like to see a lot more of that happening in the field today, where physicians, there's a lot of small practices in California. There's precious few truly independent practices because they all belong to something, an IPA, a foundation, one of those things. I'd like to see a lot more of them step into the middle and say, okay, we'll do this on behalf of the providers in our network, because it really was the only way that EHR adoption worked at scale. And I think it's probably going to be the best way for data exchange to work at scale.
Yeah, that's a great insight. There are these kind of aggregators, I'm going to use that term really loosely, that could assist. Yeah, Adam, go right ahead. I was just going to ask you.
I guess what I'd say, I actually am a lot more hopeful for the ability, again, because it aligns so much with now what's called promoting interoperability, right? Like the meaningful use program has become promoting interoperability, and TEFCA, it aligns so closely with it. And we as providers, whether it's smaller practices or giant systems like Sutter, have been that under that paradigm for a very long time. And so we do have EHRs in place. Those EHRs, for the most part, have interoperability capabilities built into them. Now, that's not universal, because there are some people for whom meaningful use didn't have any financial impact. If you're a pediatrician and you don't see Medi-Cal, you're not seeing any impact, right? Then there's like exceptions to these rules, but for the most part, the provider community is on it. What I'm curious about, and I'm not the one to speak to this, we have a payer here, we have small practice, provider practices, we have hospitals. What on the panel we don't have, but we have a lot in the participants are public health and CBOs or community benefits organizations or community service organizations. And really, my impression, having worked in this in community, I've worked very closely with the Santa Cruz community on this, is those organizations really, they're the ones that really truly don't have the infrastructure or the expertise or the bandwidth or the monies to update their systems, to respond, to take in this data, to analyze this data, to change their workflows around how they collect the data now. And so I am curious, and this might require us to wait for another cycle of boom of the California, up and down of our state budget. But I'm curious how we can support, because really in the health system, I do feel like from provider to provider, and I know it's exception for some very small practices, but we're getting pretty good because of these IPAs of sharing our data with each other. It's really these sort of non-classical medical, but very important to the patient services that we are not as good at. And I know that the insurance companies will be good at it. They're and we want to be able to share with them, whether it's through California Data Exchange Framework or through other means. But it's what's so unique about the California Data Exchange Framework is the way it wants to bring in the public health and the community benefits organizations that are not included in the federal bills, and whether we can do that, or there is a roadmap in TEFCA for public health, but it's not quite played out yet. And whether we can do that well depends on resources for them. And I don't think that they're going to be able to do that alone.
Yeah, I'm going to parse those topics just a little bit because each one is worthy and interesting on this. So one of the things that I think is so right about the data exchange framework in California is that it brings social information and those community-based organizations into this sphere, in addition to the clinical care delivery system that in health plans that we would typically think about data movement between. I can tell you from the MX perspective, we see a significant uptick in those community-based organizations wanting to engage, willing to engage. I think your note, Adam, about the sophistication of technology in that universe kind of broadly could stand to be funded, I think, and enhanced. And I think there are also a number of technology vendors that are giving that some due attention. Curious from your perspectives, what are you seeing in your worlds on this? Are you seeing an uptick? Are you starting to see that social information flow? Any thoughts on that? And then I'll come back to public health.
We're not getting information from that's usable, at least. I mean, it might flow in some place, but like usability of data is a big passion of mine too. And certainly I wouldn't say that that's flowing in from the community organizations for us.
Okay. David or Krishna, any reflections from your vantage points?
I think there's pockets of it that are happening. I think San Diego County, just by and large, is ahead of most of the rest of the state because of their community information exchange. So I think there are pockets where it's actually working very well, and there's some models we could look at. I mentioned this earlier. I think we've been kind of surprised actually at how many community-based organizations, again, not required to sign, who have stood up and signed. Adam, to one point you raised, they were made eligible for one of the rounds. I forget which one it was. One of the rounds of the Data Exchange Framework grants, and quite a few of them came forward and got pretty significant money out of those grants. So I think there's some stuff that's happening today, and I think we're hopeful that more of that's going to happen in the future, because then the other issue, and I'd love to hear what the payers say about this, but is of course CalAIM. We're going to have to. Like, we can't do CalAIM without bringing those folks into the fold. And so I'm just hopeful that we can just go out and find more of them and get more of them involved.
You read my mind, David and Krishna. I'll be curious to get your thoughts on this. I think that's the biggest driver that we are seeing is really CalAIM and enhanced care management. There are a number of organizations that are community supports, or they are part of that enhanced care management structure, community health workers, really starved for information on the members and the patients they're caring for. Krishna, thoughts or perspective on that?
I agree. I think we're seeing it in pockets. I think particularly as a Medi-Cal managed care plan in Los Angeles and San Diego, those are the pockets where I think we're seeing and engaging in the sharing of data, particularly on social services, social needs there, with a lens on certainly CalAIM. Erica, you're spot on. CalAIM and the enhanced sort of ECM work there. It's also shining a light on just like the technology opportunity, the privacy security training, some of the points that both like Adam and David brought up as well. There's a need there. There is a need to lift and support the organizations that are coming to light as well. That's sort of separate from DXF though, right? So I think that's it certainly is a burning platform, is the sharp end of the spear. And I'd love to, of course, see this sort of scale beyond our Medi-Cal members to broadly just all our members as well. But those are some of the bright spots we're seeing.
You raised privacy. I'm going to put public health into like a little holding bucket here, and we'll try to come back to it. You raised privacy and security, and that was also on my list to ask the group about today. It seems that there's a cyber event constantly. And I think there is trauma for most, if not all of us, from the Change Healthcare event. And I'm not sure how much vetting there is of DSA signatories. And so I'm just layering, you know, we kind of layer these environmental challenges on top of the implementation space for the data exchange framework. I know for us, again, on a qualified HIO side of the universe, it has prompted us to implement even more diligence than we've had historically. And we have to balance information sharing with privacy and security, right? Diligence. Curious what your thoughts are on that, and any reflections on maintaining privacy, both, and we can split them apart if that's helpful, privacy and or security in this new data exchange framework universe.
I mean, and so there are two separate issues, and I do think that on the security issue, again, that goes back to resources and both. You know, I've been involved a lot with Sky over the years. We at Sky are hiring like a security officer. The sort of the security framework of smaller organizations needs to be looked at, but some of these attacks have been on massive organizations with very large security teams. It's a hard environment. Certainly the discomfort for HIPAA covered organizations sending patient information to non-HIPAA covered organizations, despite the regulations, is uncomfortable just because of their lack of experience and with security and so that's real. It's also not something that is super specified. Again, it goes back to the sort of standards. There are, you know, I'm not a technical security expert, but there's less specifications, less depth of the specifications about security in this regulation than some of our other federal regulations. And it refers to some of the federal regulations, which is a very fair way to do it. And we very much appreciate what it does. The privacy thing is super interesting because privacy overall in health information exchange is a pendulum. And we are on a swing in a different direction than we were 4 or 5 years ago. And some of that is the Dobbs decision and state level laws about it. In our state, that's AB 352, but Maryland has their laws, other people have their laws. But part of it is patient activation. You know, I would say the vast majority of my patients are more concerned when I don't see some of their healthcare, right? They're like, why don't you have access to that? This is 2024, right? But the ones that are most upset are the ones for whom I can see healthcare that they don't want me to have access to, right? Like now that's relatively rare. It's a much smaller proportion, but they're much more viscerally affected by it, right? And so the idea of sort of segmented consent is something that many people across the industry are thinking about, but it's really hard, like to put on patients some sort of complicated grid of what type of data they can share where, and even can we segment it is not really something that we know yet. And we don't know really whether patients can do it. So we have a very long project of over a decade of basically opting all our patients in across the board to information exchange and setting that expectation and that norm. And now we have maybe a swing back, and where that swing is going to end, both at the federal and state level, I don't know, but it's a real concern. There are legitimate positions on both sides of each use case, and it's hard to talk about in the global because really when you get really granular, it just becomes harder, and each case becomes harder. But yeah.
It's so true. And I do, the Dobbs decision really elevates this kind of jurisdictional question, I think, in ways that, to your point, Adam, 5 or 6 years ago, I actually think I had some colleagues who were like, yeah, state stuff doesn't really matter that much. It's, you know, we have federal solutions. And I think Dobbs has changed that, and local laws like AB 352. David Ford, I know you must have thoughts on this, and Christian, I suspect you do too.
Yeah, well, I'll say a couple of things. I mean, one, yeah, Dobbs has scrambled everything in the world of data exchange, particularly when it comes to the national networks, right? And I've been kind of watching the Q&A box, and I am just amazed that no one has said AB 352 yet in the Q&A box. I assume that's coming. But from the physicians, particularly small practice physicians, you know, one of the issues we really hit is that there's two levels of concern. Yes, physicians are concerned about their patients, the privacy of their patients' data, where is this going, who can see it, all of those sort of general things. But then also, and I should say, and that I think Adam mentioned it, this gets compounded as you bring the sort of non-traditional folks into data exchange, right? Who, you're absolutely right, do not have the same history with HIPAA, with CMIA that the medical world has just had to learn over the last 40 years. So there's sort of that concern, but then from the physician, remember, there's also that concern about their own personal liability if that data is breached, right? And the breach notification rules and their liability under HIPAA and under CMIA for they have that responsibility for what happens to that data that makes it difficult to think about engaging in data exchange, especially with non-traditional providers. So I think that's just an education effort that has to happen about, organizations like yours, Erica, and how do you actually handle the data? How does this data move? Who can see it? Who can see what data? I think all of that is just, we have to pull back the veil a little bit to get physicians more comfortable with it.
Yeah, we have definitely heard from, I would say probably more large health systems than the smaller organizations on our network, questions about, is this data that I'm sharing going to go to CBOs? And if so, what are the conditions under which it goes? And there are big questions to sort out there. I know we have 17-ish minutes left, and this leads me to a topic of consent, and I see it in the Q&A here also that I want to elevate. Before I do that, Krishna, I'm just curious, any other thoughts on the privacy and security front here?
The security piece, definitely a very clear and present danger, right? Like unfortunately, it is this sort of price-setting business in 2024, right? We have systems that are online and connected, and so I think continuing to sort of like work through the sort of a risk and likelihood type thresholds and putting in whatever guardrails the companies big and small can do, I think will continue to be key. Obviously, there's only so much you can plan and predict. There's obviously, there's always something new coming up. It feels like the change stuff was obviously a pretty huge blow to the system as a whole there. But they continue to build off the frameworks we've had, the HIPAA security work, the HITRUST work, I think are all starting points. The fact that I think the Ohio's are required to be HITRUST certified, I think we'll get one layer of protection there. I agree with Adam's and David's concerns on some of the non-HIPAA entities. I think adds a new twist to the tail. I think it again, increases the burden of education, training, equipping, and I think there's just more work to do to bring the healthcare system, the broad definition of system forward as well beyond the HIPAA entities. So opportunities, but also, I guess more caution. But we should still keep moving forward, right? We can't stop because of these concerns. And it's obviously, as it is a clear and present danger, but it feels like we need to keep moving forward and finding ways to sort of reduce the risk and reduce the likelihood as well of these issues happening.
Yeah, I agree. I think moving forward is the right approach. And having processes and structures that are multi-stakeholder, right? And engage individuals as well as organizations in that decision process. Consent, I just want to turn to consent really quick, because when an individual authorizes their information to be shared with a community health worker or with a community-based organization, or sensitive information to be shared with another care team, that gives us a lot of comfort and a lot of cover in that disclosure. And I think one of the potential challenges for us as we move, to your point, Krishna, keep moving forward in this space is we want to move quickly. And sometimes that means building tech and building infrastructure to support those use cases. I would hate to see a scenario where California has, I don't know how many different consent structures or registries that are, again, this, in my personal opinion, would be duplicative and inefficient. I would love to see the state fund, although I know we're in difficult financial times at a state level, a consent registry, really a place of truth where individuals could log their consent preferences, and then organizations like MX and other qualified HIOs or data trading partners could if they could expose an API, we could hit that and say, okay, has Erica Galvez consented to this? Any thoughts or reflections on that idea and the state of consent generally right now?
You know, it's funny. I'll go back to that one thing that I think is the real challenge. Like, we can all come up with sort of different architecture for consent, but I think the idea that patients will be able to manage that architecture is the most challenging part. And I'd like to see that even on a small scale, which we are doing some testing at Skyo for something of that nature. But I think that, like, you know, consent's really complicated. I saw Stephen Lane commented about like creating data sets that would have, you know, you'd have your reproductive health, you'd have your substance abuse, you'd have your behavioral health, and you consent to the different pieces for different use. But like, the truth is, that's a management of a grid that is really complex for the average user and changes really quickly in their minds and what their preferences are. And so I'm not saying we shouldn't embark upon it, but I'm just saying that it's really easy for like us technical and like savvy and like think about it all the time, HIE people, to sit here and come up with a system where a patient could in theory express their preferences, but translating that, I mean, it's sort of like the digital health in general, like how many of those apps have failed because people just don't like going into things and clicking on a bunch of different things. And I think these consent management things will be a big barricade to them, is my prediction.
Cautionary note. That's good. David or Christian, additional thoughts?
Adam took most of what I was going to say. It's complex. I think traditionally we thought of consent to share data as yes or no. And I think for the vast majority of patients, it's maybe. Or it's yes to some data and no to other data. And so I think the first step that needs to happen is I think the technology is going to have to catch up, right? And again, because of the fights we're seeing right now about the implementation of AB 352, which I'll give the very short version in case anyone is not familiar with California state law that requires segmentation of certain types of data in electronic systems, largely, again, a post-Dobbs thing. So the technology is going to have to catch up on the EHR side to make sure that we can segment that data, and then consent kind of has to follow once we can actually technically do it.
Yep. Krishna, any final thoughts on?
I liked your sort of, I think having some sort of shared consent sort of architecture framework and a registry, I think could be cool. I mean, obviously, the feasibility of implementation, different story there, but I think it's particularly, as we are seeing the proliferation of like digital health, digital therapeutics, like, obviously large health systems payers are managing consent, but then we're also introducing, we've got a platform called Wellvolution where we want to, introduce digital therapeutics to our members. And so being able to move consents over, I think, could be interesting. Finding ways to make it seamless, I think, will go a long way. And particularly with, there are sort of segmented consults, particularly around like what payers can see and not see, and things that, we've not paid for. There's some nuanced concerns as well come to the mix. So I think, given that, I don't know, much like provider directory, this is sort of a shared problem we all need to get better at. I think having a sort of a shared framework and a registry is certainly something worth thinking and exploring for us as a state.
Excellent. Okay, we have 9 minutes left, and there are so many additional things I want to tee up. And I know we have a bunch of audience questions, and I promised I'd come back to public health. Can we just really quickly on the public health front, can I ask the panel what you think the single most important thing we could do, again, with an eye toward implementation of the data exchange framework, to advance our public health vision, and really that the vision for connectivity between care delivery, public health, and the social support side of the universe that we've heard our colleagues at Cal HHS talk about, I think, many, many times. Any thoughts on key things we could or should be doing to advance our
So-
connectivity of public health?
Erica, I will almost go back like one step and say that one of the things I think the California Data Exchange Framework did was it tried to be all things at once. And
Mm,
and public health is a great example of that. And I actually think the most useful thing if the legislators wanted to get involved again, because it would take sort of legislative action to do some of this, would be to attack narrow use cases first. And in the public health case, if we could do standard electronic case reporting through CalAIMS to every county in the state or directly to the counties, but we did the same electronic reporting everywhere, that would be a tremendous it's true for what we are, which is a multi-municipality, like we're over, quite a few counties across the state. It would be tremendous for us. But I know it'd also be tremendous for the small practices who are trying to keep up. If there's one standard way to do this stuff. And so I think having a more use case focused California Data Exchange Framework that tried to master one thing really, or a handful of things really well, whether that's referrals, whether that's a particular part of public health. For me, it's case reports, because I think that's right now completely heterogeneous, and every municipality wants to do it differently, and therefore we're not getting as good data and as consistent data. But to me, in some ways, it doesn't matter which. It's let's pick one. And let's use the California Data Exchange Framework to work on these individual use cases where we can have standardization rather than trying to boil the ocean.
Yeah, I love it. Start small and specific. David, any thoughts?
I'll just say real quickly, I agree with Adam. We should focus on a use case, and I'll go one step further and say, I think the logical place to start in California is housing. Housing
Great.
and security, right? If we could just, it affects so many, we know it's a problem in California. We have expensive housing, we have a homeless issue. So many patients, in our Medi-Cal system do have housing insecurity, and affects so many things about their health. It just seems like the natural one to me to start is, can we just make that data available at the point of care that yes, hey, now this person's asthma is not getting better because they're sleeping on the street. It's, to me, the logical place to start.
Yeah, love it. Krishna, any thoughts on public health?
I like the use case idea. Nothing new to add there. I think for me, it would just, the approach for just broadly data exchange framework itself, right? Sometimes it feels like we're trying to do too much. And I think even for the non-public health use cases, we're trying to start with can it help with quality? Can it help us reduce our provider administrative burden for risk adjustment? Or can it help with sort of care management? I think that's the lens we're trying to look at, just data exchange period. And so extending that sort of concept to public health and sort of use case, test, learn, scale, I think is good advice from Adam to others.
That's great. I'm going to add to that poll and be super, super simple and just say, I think counties were encouraged to participate in the data exchange framework. I don't think they were required. And so much public health occurs at the county level. I think one place to start, in addition to really narrowing our focus in terms of use cases, get the counties engaged, get the public health departments at the county level pulled in. We have 5 minutes left. Audience questions. There's a mix of questions that have come in during the webinar today, and some that folks submitted actually as they were registering beforehand. Let me just mention a couple that I don't know that the panel can really opine on, but I think they're interesting. One is, how has the data exchange framework improved data between state agencies or departments? Another is, how long will it take to show objectively improved utilization, quality, and cost savings from this policy? Also super interesting. Don't know that we have the right mix of folks to opine on that. Here's one that I think I'd love to hear the perspective from the three of you on. Without any enforcement of AB 133 and the data exchange framework, right? We talked about probably not having enforcement for some time. Is there a real reason organizations should comply with it? maybe even legally speaking. Any thoughts? I mean, I have some opinions here, but I'm curious from your perspectives. Without enforcement, is it worth it?
Well,
Adam, this looks like
many
this is
healthcare,
troubling you. Go ahead.
many healthcare organizations got letters from payers, from one specific payer, sort of
Guilty.
saying that we were out of compliance and needed to be in compliance in order to stay on their panel. And now, that matters to a lot of health organizations. I think from Sutter's perspective, we were the first signatory of any large health organization. We want to comply. We believe in this, and I think, again, I think providers across the state, I imagine David feels the same way. They want to. I mean, we want to be part of the public health solutions. We want to be a part. We want our payers to be able to do better manage care of the lives that they're responsible for. So we want to comply. I think the issues that we've talked about around security, around HIPAA, around unusual use purposes of use for which we might not have the segmentation tools for, and for just sort of vagueness. I think those are the biggest obstacles to us right now, not the desire. I mean, obviously, if it was an incredibly expensive mandate, we probably wouldn't buy a lot of new vendors and services for it. But right now, we are not adding a lot to our bottom line to try to do what we can to comply, and we want to be good actors.
Great. David, thoughts?
I'll just say, and because I was a little flip about it earlier, but there is an answer, right? When physicians say, well, why would I do this if there's no penalty if I don't? And I like the term Adam used, vagueness. We have to take HIE from being a vague concept into something like very specific, which is you tell us, as I've talked to physicians, and I know many people who are listening have talked to practices about HIE, wouldn't it really help you to know what's going on with your patient? What else has your patient been seen? Was your patient in the ER and you didn't tell you about it? What medications has somebody else prescribed to your patient, right? Adam's absolutely right. Practices want that information. It's helpful. It helps them get that 360 view of the patient. And I think it's more aspirational than coming to them and saying, well, do this, or you're gonna, for some command and control reason, like we tried to do with meaningful use and the Medicare cuts for physicians who didn't get to meaningful use. But just to be more hopeful, more aspirational.
Yeah, I love it. Okay, Krishna, you're going to get the last word on this because we have less than 1 minute to go. Is it worth it with no
The
enforcement?
last word. For me, I think the focus we've had on data exchange is how can we create value, right? How can we create value for our members, our shared patients, be reducing provider administrative burden? Like that's the lens we've taken, for the last sort of decade of sort of this, data exchange work before the DXF as well. And so I think there's still value in looking at how do we make a better healthcare system together, there. But that said, I mean, it's always good to have other layers. That this is the sort of the Swiss cheese approach to sort of moving the world forward. So I think enforcement, we've, as Adam was saying, like we've leaned in, right? Like this is the law of the land. Like we want you all to comply. Like, we're doing our part to make sure that we can continue to move this conversation forward. While at the same time, it's coming from a place because we want better quality. We want less duplication of tests. We want holistic clinical information flowing, through certainly the healthcare actors that need them. And so, and to make it available to our members in their consumer member health record. And so the reasons are all right. And then the strategies is just, how do we continue to show value, but also continue to sort of reinforce the fact that this is the law.
Yes, it is the law. It is, so complying with the law is always a good thing. And you heard it from our colleagues today. There are so many potential benefits. I'm sorry we have gone 1 minute over. I want to thank Adam, David, Krishna for the conversation today. It's been so much fun to talk to you, and thanks to everybody else for joining the conversation. I think we have enough questions in the Q&A to do 1 or 2 more of these. So maybe there'll be a next time. Thank you, guys.
Thank you.
Take care,
Thanks all.
everybody.
Bye.
Bye-bye.